Good morning, everyone. First of all, I'd just like to thank the committee for asking me to come and speak this morning about a topic that's really very close to my heart. So I'm going to talk a little bit about compassionate extubation in the community, but I'm also going to talk about end-of-life care in the ICU in general, and children being discharged from the ICU to destinations that may be a home or hospice, or indeed a local hospital, regardless of their level of need. And it's a relatively new area in intensive care, and I'm delighted that Ireland is a country that is really making strides to try and make this a very effective service. But as Alex and Marie and Joan have alluded to, a lot of work is still needed, and there's a lot of resources that need to be put in place to make this a robust service. So I'm going to steal a slide from my NICU colleagues. So this is what we want when a child comes into the intensive care. This is a little neonate who's graduating today. He's 28 days in the unit, 28 days behind him and a whole life ahead of him. And obviously that's the goal of what we do in ICU as well. In the ICU in Temple Street, we see about 350 to 400 children a year. And if they all ended up looking as happy as this little chap, we'd be delighted. And we're very fortunate. About 95% of our children survive to ICU discharge, which is a really high number. And unfortunately, there is another reality. And this is a very upsetting picture, but this is the extent to which our care does go at times. And not every child can be saved. Children with far less complex needs as this child may not survive, and in fact, children as sick as this often do. In Temple Street, we have between 16 and 23 deaths a year. And it's probably not a surprise to hear that between a quarter and a third of them have chronic life-limiting conditions before they enter the ICU. And I'm sure most of you have experienced over the years an increase in that proportion. And that's because we're becoming technologically more advanced. Families have higher expectations about what we're able to achieve, and more hope that we'll be able to come up with a way of getting them home. We in Temple Street, for the last 2 years, have offered and frequently offer families a preference of where their end-of-life care might take place. And so far, half of the families offered have chosen to leave the ICU. The destinations that they go to include home, a local hospital that they may have been cared for years, children's hospice, or indeed back to a NICU where most of their care may have been up until they were transferred to us. And I don't know if that number seems a little low to you. The international experience, certainly for children with oncological diagnoses and advanced discussions about end-of-life care, closer to 70%, 70 to 80% of families would choose to be at home. So why is there a gap in paediatric intensive care? And I like this. I don't like this photo, but it's a very true photo, and I think anyone who works in ICU would probably agree with me that this is not an unusual scene in an ICU environment. A baby connected to a huge amount of technology and a mother very remote from that child. This mother is not changing her baby's nappies. She's not feeding her baby. She's not holding her baby. And when you survey intensive care doctors and nurses about where end of life should be for children in ICU, 90% of them choose home. And when you survey parents, it's 70%, and our families, 50%. So what is it? And I think Alex alluded to this, why do some parents choose to actually have their end-of-life care for their child provided in the ICU? And I think there's probably two sides to it. For some families, there's reasons not to go home. Do you fully accept that this is the end of life for your child? That's a big one, and it takes a long time for some families to come to terms with accepting that where we are is not going to be reversed. Not wanting to give up. So many of our families do accept that they're in an end-of-life situation, but yet the idea of removing a breathing tube, disconnecting a face mask, stopping an inotrope, feels like they're letting go and feels like they may not be able to live with that decision later on, even though deep down they know it's the right decision. And for a lot of families, particularly those with acute illnesses that lead them to come to ICU, there's a real fear. A fear of what their child will look like, the fear of being alone when it happens, the fear of their child suffering or being in pain. And then memories tied to home or hospice, particularly again for families of children who came into ICU well. So their bedroom is where they're happy. It's where they wake up and say hi to their parents in the morning. Some families just can't bear the thought that that would be the place where their child passes away. So it's really important that we respect a decision not to go as much as impose our own paternalistic ideas on it. And then there's lots of reasons to stay in an ICU. There's a huge support system, social work, chaplaincy, doctors and nurses, round-the-clock care in a very controlled environment where things are probably not going to happen without a plan in place and take them by surprise. And a little bit less stress and organisation. You know, you take a typical Irish mammy and she gets home with her critically unwell child, and next thing there's 25 slices of Brennan bread sandwiches being made and 45 cups of tea, and you know, everyone's over visiting, and all of a sudden they're being pulled away from what's most important, which is one-on-one time with their child. And it sounds a little bit, you know, flippant, but it is a real problem sometimes for some families. So for all those families that stay, there are also families who go and who choose to go home. And there aren't a lot of reports in the literature of this, and certainly not a lot from the family's perspective. There was a lovely retrospective study which spoke to families about 6 months after they went home from an intensive care setting and where their child was extubated when they got home. And I've just taken a few quotes from that paper. The pictures are not linked to the quotes you see. So the first one is that, you know, I wouldn't have had it any other way. If I couldn't have him, at least I got one thing that I wanted for us, and that's to bring him home. And another family, it gave me a sense of closure. I don't know how I would have felt if I hadn't been able to get him home. It was better to be here, and he seemed much more relaxed and ready and accepting himself. And for infants, it might be particularly difficult. If he'd never come home, we would have come back to a never-used nursery, and that would have been hard. And another mother, bring him home well, but since that didn't happen, just to have him come home, if only to pass. I've also met families where we've offered to bring their child home, a neonate home, and extubate, and they've told me that nursery hasn't been a nursery yet, and they couldn't bear the thought of their child only being there to pass away. So we can never presume about what a family might want, but the wonderful thing is that we now have a possibility of being able to offer them and have them choose. And so is there a gap? Is there a middle ground between the intensive care unit or the ward and home? And we're very fortunate in Ireland that we do have that gap, and that stopgap is the hospice. It's not frequently utilised for end-of-life care, but it offers a phenomenal service, an overwhelmingly fantastic service for children for end-of-life care. And it offers a home away from home, a calm and quiet and non-clinical environment, somewhere where they can have experiential, sensory experiences and legacy building with their family, and most importantly, the entire family gets cared for, and siblings are provided with distractions, and the family are cared for in their entirety. And for families who have gone through that end-of-life care in the hospice, they report that it's a home and away from home. They get guaranteed clinical support. Bear in mind that many of our children that we extubate or we may remove inotropic support from, it's not guaranteed that they're going to actually pass away. And so trying to parallel plan and plan for their needs beyond the extubation period can be fraught with difficulty, as I'm going to show you, whereas the hospice does provide that guarantee. It prioritises family time and it supports the whole family. And then there's families that just can't leave the ICU, or families who choose to stay. And we really do our very best to provide an environment that is as non-clinical as possible within the constraints of our unit. We provide as much kangaroo and close care as possible. We celebrate life with parties, and we celebrate major events. And we provide as much extra therapies as we can. We do the portraiture and hands and clay making and all these things to try and make it as best an environment as possible. And the UK have looked in detail at the reasons or the barriers to withdrawal of life support, life-sustaining therapies outside of the ICU, and have come up with a couple of things which I think resonate with the Irish situation. Lack of healthcare provider experience. Bear in mind, this is not a common event, and it's not part of any of our training. We're all trained to be intensivists, and we're trained to be transport specialists, but we're not trained to necessarily withdraw life outside of that environment, which is very controlled and we feel very supported in. Access to a paediatric critical care transport team. Our Irish paediatric acute transport team is not being designed for this. We are designed to retrieve children who are critically unwell from a regional hospital and bring them back to a tertiary ICU. We don't have the funding, we don't have the resources to run a service such as this, and so far we have done it for our children by being able to mobilise a second team through goodwill, but it's probably not sustainable. Access to a hospice bed. Ireland has the Laura Lynn Hospice. So far there have been no issues, but it is a limited resource, and it's not unrealistic to think that it might be a problem at some point when a child needs a bed there for end-of-life care. Access to the home, something I learned the really hard way. We have a 1-ton trolley, and you might have a very large child with a ventilator, 7 pumps going, and a narrow house and a flight of stairs to the bedroom, and all of a sudden you have to be thinking on your feet on how you safely get them in the door and home. And then patient instability and risk of death before arrival home. It's a really big issue, you know. Most of these children start their trip with a do not resuscitate and a very clear resuscitation plan that does not involve reintubation. And you're taking them out of a safe environment, potentially destabilizing them, and you're hoping that you get them home safely. And so it's very important to be very open and honest with the families, most of whom have told me, I would rather have my child pass away trying to get home than not try to get home. But again, they need to have an option and a choice. And then finally, an impact on ICU and transport resources. As I said, we've had to mount a second team. We take nurses from the ICU. There's a huge positive drive to provide this service, but as yet not the resources to guarantee it can happen for every child. And so I took the opportunity to look internationally at what has been published on this area. The bold at the bottom is Temple Street's experience, and you can see the frighteningly short list of, this is international publications on extubation and withdrawal at home from an ICU discharge or a NICU discharge, and to date there's only 49 children documented in the literature, total. And the latest publication was in 2017 in the Pediatric Critical Care Journal, which is a relatively high impact journal for pediatric critical care, and they had a case report of 3 children. So the first reports were in 1994, and it's taken 23 years to get 49 children home. I have a feeling a lot more happens than is being reported, but again, it goes back to what Alex was saying about shared learning and understanding what other people are doing, because we're all facing the same problems, and it would be great if we could share information a little bit more frequently. What we see from this is that the vast majority of children are being mechanically ventilated at the time of discharge. Very few of them are actually on hemodynamic support, and that goes back to the feeling of stability and the feeling that you'll be able to get them home safely. Destination is usually home or hospice, and then if we come on to the little red circles, this just is a really important point about outcome. You think a child who's going home ventilated or on non-invasive or on inotropes, that we've usually tried to extubate, we've usually tried to get them through it, and they failed and have been reintubated or have gone back on their support. And there's a real expectation that we're looking at quite a short time frame from transport home to passing away. And what we've found in the literature is about 25% of children survive for more than 4 days, and in our own experience, 50% of our children have survived for more than 4 days. And that goes back to parallel planning. It goes back to what are you going to need in the community after this child goes home? Because obviously my part is very small and quite easy to organise, but what goes after me is going to become a really important part of the puzzle. So this is the Temple Street experience. We've transferred 6 children home who've been intubated or required non-invasive ventilation so far since 2015. And so far we've looked after 12 children who we've managed to get to an alternative destination, regardless of the level of respiratory support at the time. Our children range from 28 weeks up to 13 years. The average time in the ICU is between 2 and 3 weeks, and that's very consistent with the international reports. And I think it just takes time to come to an understanding that you're in an end-of-life situation, to get the family on board with that, and to give them time to think about their preferences, and ultimately for us to plan for that discharge. The vast majority are on some form of respiratory support and not on hemodynamic support, and we've had half of our children be discharged home and almost another half gone to either a local hospital of their choice or a local NICU where they may have had primary care. We've just had 1 child transferred to the Laura Lynn Hospice. And again, if we look at our survival overall, about 50-50. Some have passed away very, very quickly, and others have gone on to survive completely and are still with us, and others have survived for a number of weeks following transfer home. The map just shows you the geographical dispersion of these children, and shows you that whatever solutions we come up with it needs to be national, and needs to be, there cannot be a postcode lottery for these children. These children are dotted all over the country, and we need to be able to guarantee some resources for all of them, regardless of where they live. I just thought I'd take a minute just to take you through 2 cases that we've done, just to give you an idea of what it involves. The first child was a young man who came into our outpatient department one day for a routine review and was found to be in significant respiratory distress at that meeting. He was transferred over to the emergency department for an assessment, and ICU were called down to review him, and it became very clear that unless he was intubated and ventilated, he was probably not going to survive very long. His family had thought long and hard about this long before he came to that appointment, and they were very clear that they did not want him intubated and did not want him to pass away in ICU or Temple Street. We took no offence. What they did want was to go back to their local hospital, where they knew their family and friends could get there to see him, where they knew they'd have clinical support by staff that knew him and cared very much for him. There wasn't a lot of time, and so a lot of people got mobilised very quickly, from palliative care to our transport service, who put on a second team, to the local hospital who made a room, who found a nurse, to the chaplains and to the extended family who were all planning to be there. We managed to get him there within 2 hours, and he had a number of hours with his family while receiving some non-invasive support and being made comfortable with the syringe driver before he passed away in the presence of all his family and friends. And I know that his family were very grateful that we were able to do that. So that's a very sudden but doable short distance transfer that made a difference to that family. And I think on the other end of the spectrum was a little boy last year with a degenerative metabolic condition who got intubated and ventilated for a lower respiratory tract infection and transferred from his local hospital to us. And literally the first day of his admission, his parents said to me, "What if this doesn't work? Can we take him home?" So again, they came having thought about this. And so we very much from the beginning parallel planned for his admission. We did everything we could to treat that pneumonia, and we did everything we could to plan if it didn't work. And we actually made it to extubation, cleared his chest, got his tube out, and unfortunately his condition had deteriorated to the point where he was no longer able to maintain his airway. And his parents asked us to re-intubate him after 2 days of struggling, with a view to getting him home. And so he was re-intubated, and through the phenomenal work of our palliative care team in Temple Street, we're able to set up enough staff and enough people locally to be able to take over his care when we got home. We set up a transport team. We brought him home intubated and ventilated and very comfortable. He was spontaneously breathing on the ventilator. He was just dependent on the tube itself for his airway maintenance. The ambulance men carried him upstairs with the ventilator attached. We tucked him into bed, tucked everything underneath, and just stayed just very close, just outside the bedroom door, while the family had 2 or 3 hours together in the bed with the siblings. And they really had some special time. And when they felt ready, we came back into the room and we extubated him. He passed away between 5 and 10 minutes after the extubation and was very comfortable throughout. And we then stayed with him, and we provided the care that we would provide to any child who dies in the ICU. And we made sure that the local team who had met us, the GP, palliative care service, were all there for a handover, that everyone was comfortable with what had happened, and that the family weren't left without support before we headed back to Dublin. So it was a real honour to have faith put in you by a family to be able to provide that service. And I know from that family's feedback is that they were very grateful that we were able to do that for them. What I want to do is be able to do it for everyone. So where do we go about getting that? How do we roll this out? And we're very fortunate, again, as Alex said, if someone's written the book, why would you rewrite it? And so ACT in the UK, the Association for Children's Palliative Care, have come out with a really nice framework for palliative extubation in the community. I see no reason to rewrite it, except making some minor tweaks for the Irish context. I think what Alex says is important. The framework is just a framework. It just gives you a scaffold to build on, and what you have to do then is develop local guidelines and get everyone on board in terms of what you practically want from every part of every piece of the puzzle. So the basic framework that they've laid out is they've built 3 stages into this process about getting an extubation done in the community. The very first one seems quite obvious, but a decision to withdraw life-sustaining therapies is often the rate-limiting step in this and takes the longest time. Sharing the news with the family, having them come to acceptance of that news can take anywhere from hours to months, as you've probably all seen in the media over the last year. Coming up with an agreed plan of care. And that might be like my example, my second child, where from the very beginning it was, let's treat this pneumonia, but let's also plan for what happens if it doesn't happen. Stage 2 is the practicalities of withdrawing life-sustaining therapy. How are you going to do it? Where are you going to do it? Do you have an end-of-life plan? And planning the extubation itself, because it's not straightforward. And finally, care at the time of death. So enabling end-of-life wishes for the family, legacy building for the family, and continuing that bereavement support beyond the departure of a transport team. When we talk about an agreed plan of care, these are things we've learned sometimes the hard way. You need consensus. You need consensus from the ICU team about the fact that you're in an end-of-life situation. You need all the consultants actively caring for the child to be in a consensus about the diagnosis and about what the right thing is to do moving forward. You need the parents, siblings and guardians all to be in agreement with that, and that can take a long time. You need to discuss the end-of-life environment, and you need to explore family preferences for end-of-life care. And I say preferences for a reason, because you can ask a family what their choice is without guaranteeing that you're going to be able to deliver it. And I still think that even if you kind of know you're not going to be able to get this child home, a family should have the option of saying that that's what they would like. And often there's a middle ground you can come to, an agreement you can come to which is acceptable to them. So it might not be home, but it might be the local hospital. It might not be the local hospital, it might be Laura Lynn. But there may be an option, but you must know what they're thinking to start with. It should really be irrespective of illness severity. In this day and age, it's unusual that I couldn't get a child 2 hours down the road with medication if I had to. We are getting better at guaranteeing stability, and we're getting more and more comfortable now that the AIIHPC team is up and running about being able to deliver these high-tech treatments while en route. And really irrespective of length of stay in the ICU, so 2 to 3 weeks is a long time, and not every child has 2 or 3 weeks. So being able to mobilise a transport team, being able to mobilise the local resources needed over 2 or 3 days would be a real challenge, but would open it up to all children to have access to this a mode of end-of-life care. Obviously, early liaison with appropriate teams and services is going to be really important. Sorry, I'm going to say this a lot of times, parallel planning, really important. So an end-of-life plan. So you need to develop and consolidate a resuscitation plan, and we do that already, and we've got a very robust algorithm in the hospital and a very clear national document now which documents everything that we think we're going to need in terms of outlining what a family wanted at the end of life. It's really important, again, as Alex said, to talk about organ donation. A lot of families don't realise it could happen, and is it possible? And I'd hate for a family to find out in retrospect that something could have been donated that they would have felt very positively about. Post-mortem examination. It's really quite important to establish with the coroner that there's no reason that the child couldn't go home or couldn't go to a local hospital, and important to offer the family a chance to have a post-mortem so that they, if there's any questions they have about their child's illness, can be dealt with and alleviated. Symptom management and survival expectations. And I hope the slide I showed you about how long children survive after we've extubated should highlight how important it is that we're really, really terrible at giving survival expectations, and it's very important that we don't go in and say it's going to be 2 hours or 3 hours, because if it's not, it can be incredibly distressing for a family who think they're going to have a few hours with their child to suddenly find themselves 4 days later with a child who's in distress, but they're at home, and do we have the supports there to keep them at home? Ongoing liaison with all of the people who are involved in an end-of-life pathway. Palliative care, both local and central in Temple Street and Crumlin, local consultant paediatricians and public health nurses, our GPs and our hospice, both locally and centrally with Laura Lynn, and pharmacy. There's a huge team involved in this. When we talk about planning the extubation, we need to discuss, as I mentioned, that all scenarios have been gone through with the family. So immediate death, that can be just as distressing as days and days and days. So people need to know that there's a possibility that when the breathing tube is removed, that they will die very, very quickly. And some children die within a minute or two of that happening. And so it's important that you prepare them for that possibility. Survival for hours to days would be the norm. Long-term survival, definitely a possibility for some children. Asking the family what their desired level of sedation would be at the time of extubation. For some, being conscious and being aware is really important. For others, having no symptoms at all is important. And it's very important that we listen to the families and we engage them in that process. We discuss removal of the breathing tube and inotropes and monitoring Usually it all happens together, but for some families it's in stepwise fashion, and it's something that can be negotiated and discussed with them. It's particularly families who like to monitor watch. It's really hard if you suddenly turn off the monitor. You don't want to feel like you're letting go and you're not providing care at the very end. And we also need to discuss change of heart options. So what if you get home and the family just go, you know what, we can't do it. They need to know that that's okay as well, and that's a possibility. We prefer to know before we go all the way home, but that it's still an option. And then the parallel planning, you probably are far more able to speak to this than I, but feeds and fluids is really important, particularly if survival is for longer than expected. Location of ongoing care in the event of prolonged survival. So maybe you can't resource days and days and days at home. Maybe you need to do a review after 48 hours and discuss whether there needs to be a move to hospice or to a local hospital to support that family further. They need to know about that there's a risk of accidental extubation or death en route. And we need to talk about this pain and sedation relief and make sure the regime is in place for them. A clear plan with the transport team. So when are you going to come? What time are you going to be there? How suitable is the location you're going to? And can any changes be made to that? We've had families build a ramp for us. We've had families literally take the inners of a door off so we can get our trolley in. So people will go to any length to make this happen if it's something they really want. And a clear timeline with the family and the local services about how long you can expect the transport team to remain. We need on-call arrangements for palliative care and Gen Peds, ability to admit the child if their symptoms after extubation are perhaps more than we can manage with our traditional sedation mechanisms. The availability for a GP to visit. In my experience, the GPs are there when you get there, which is fantastic. Who's going to provide medication and prescribe it? How long can you give nursing support for? Is that nursing support by phone, or is it going to be 24/7 or nighttime only? And can a family cope with that? Because families who aren't used to suctioning and pegs and feeds and might find it very stressful being left at all at home on their own. Who will certify death? And again, does the coroner need to be involved? Supplies go without saying, but again, all these things need to be thought through before you ever leave the intensive care unit. And future goals, and I guess this is, if Minister Harris just gave me all the money I wanted today, what would I envisage for the future? What I'd love to say is that families of all children in the ICU, stable enough to be transferred, are offered a choice for a place of extubation or withdrawal of life-sustaining therapy, regardless of their acuity and their background, regardless of their length of stay, and regardless of their geography. I should add, regardless of their age. I'd like to be able to offer safe home and hospice extubation in time-sensitive cases when necessary. Time-sensitive hospital transfers are probably doable, but home and hospice are a different thing entirely. And I'd like to see that framework be applied, and I'd like to see the development of an algorithmized approach to discharge planning with both terminal and parallel plans for each child formally agreed upon, so that I can safely say to a family that whatever happens when the breathing tube comes out, their child will be cared for completely. I think we need a national working group to start this process off, because so many people are involved, as I hope I've shown you, in looking after these children, and that my part and our role in transport and ICU is very, very small. And early end-of-life planning and consideration of destination preferences to happen ideally before children ever come to the ICU. There are many families who do have that conversation before they come, and I never meet them. And I'm sure that almost every family who does come through with a chronic life-limiting illness has had that conversation with somebody at some point. But it's really important that you add on to your discussion about intubation and ICU, you also add on that conversation about actually if things don't go well, where would you like to be? Because I think that little piece sometimes isn't spoken about as often. And I'm going to finish on a high note. I hope you know what this is. This is a Bumbulance ambulance, and the Bumbulance is a phenomenal voluntary ambulance service set up by Tony and Mary Heffernan, whose children both passed away from a fatal metabolic condition. And they've set up the Saoirse Foundation and subsequently the Bumbulance. And one of these ambulances is actually our main critical care ambulance for transport. And the Bumbulance are extremely supportive of what they call angel trips, or trips home for children for end-of-life care. And they do between 2 or 3 a week, and it's almost a third of their workload. The rest of the time they transfer children in a very fun and caring environment for their regular treatment and appointments. And I've just spoken to Tony Heffernan yesterday, and he's given me permission to say to you that the Saoirse Foundation will be making a very substantial financial contribution to support angel funds in Ireland every year going forward as a result of some recent lobbying to the charity. And so I'm really excited about what we're going to be able to do with that fund, but we obviously need a group of people to make sure that what we do with it is very thoughtful, and that we use that money to its absolute best. And with that, I just want to say a big thank you. There's a huge number of people I would like to thank, but I'm not going to say them all by name, but I cannot express to you how honoured I am to work in a service that is so well supported, and how visionary people are, and how willing people are just to go an extra mile for a child. And it's a great privilege to work in this health service and with these people, and I really look forward to making more networking links as we move through this, and I really hope that we can see this project through and guarantee it for every child in Ireland. And thank you very much for your time.